So I'm Gerhard Mundinger, MD, MBA. I am a craniofacial and plastic surgeon here at the Crane Center. We're talking about breast augmentation today, and the purpose of this video is to provide all the information that I know as a surgeon that I think is relevant to you as a patient, so that you can make a good informed decision about what you want for your body. So breast augmentation is a great procedure. Obviously very feminizing, not to minimize it in any way, but kind of the three big areas for gender affirming, gender confirming surgery. Breast augmentation is the least complicated. In my practice, it's actually a pretty easy path to take as a patient. And the reason I say that is I basically do one flavor of breast augmentation, unless it's a revision case or, you know, there are extenuating circumstances that are pretty rare. And that is because I've tried a lot of options for breast augmentation, and I think for trans women, the method and technique with the risks that we're going to discuss, I think gives my patients the highest satisfaction rate, looks the most natural, achieves the goals that most patients have for surgery. So with breast augmentation, the biggest risk is just understanding that you are having a material that is not your body's own material. It's a foreign material put into your body. Beyond that, it's a device that is being created by human beings. And because of those two things, breast implants have a very predictable failure rate. That failure rate has been studied out the wazoo by the FDA and surgeons in practice. And the best idea we have about implant failure rates is about 1% per year per breast. So if you're having a breast augmentation at age 20, expecting you're going to live to age 70, there's about a 50-50 chance you're going to need to have one or both implants replaced by the time you're at the end of your life. And again, statistics make no comment about each individual person. This is kind of all comers who've had breast augmentation procedures. Issues with breast implants include rupture. They include forming a capsule around the implant itself. They can lead to distortion of the appearance of the breast, sometimes pain if the capsule progresses to a certain point. And the biggest issue that we think about recently is a lymphoma called anaplastic large cell lymphoma. That is associated with textured implants, which I do not use, but there have been cases reported in the type of implants that I do use, which are round silicone implants, and we'll talk about implants in a minute. We used to think that this lymphoma was very, very rare. We didn't have a good understanding for it, but now the most recent estimates are that it could be up to 1 in 5,000 patients, 1 in 30,000 patients, and even 10 years ago, we thought that incidence was closer to 1 in 250,000 patients. Again, the majority of those were with textured implants, which I don't use. But it's something that I talk to all patients about and is really on the FDA's radar. If you choose to go forward with breast augmentation, you will sign a form from the FDA that goes through a lot of the things that I'm going to talk about and has you acknowledge as a patient that you understand the FDA's thinking about the risks that you're assuming by having breast implants in your body. Anaplastic large cell lymphoma, if it happens, most patients need chemotherapy. The implant has to come out and the implant cannot go back in. It's a big deal. We already kind of talked about capsular contracture, implant rupture. The FDA is constantly updating screening guidelines after implants are in your body. The current recommendations, and these may change, are that 5 years after implantation, you need to have either a high frequency, high resolution ultrasound or an MRI to evaluate for implant rupture. Although in many cases we're able to have insurance cover breast augmentation, the recommended FDA surveillance for implants is typically not covered. So the initial screening is 5 years after surgery, and then 3 to 5 years after that, depending upon what's found on that first screening. So we talked about lymphoma, we talked about implant rupture. For most trans women, the skeletal frame is wider than in cis women, and everybody wants cleavage. Everybody wants the implant to be up and in. The implant itself and This is just an effect of gravity, so the larger implant you have, the more this happens. The implants want to go down and they want to go out. I used to put the implants all underneath the pectoralis muscle. It was the way I was trained. It was the way most people who do breast augmentation and trans women were trained. I was never happy with those results because just, again, typically as your skeletal frame is larger, your pectoralis muscles are more developed. And with contraction of the pectoralis muscles, with the implant being under the muscle, they force the implant down and out. They also force the implant, as the implants heal and settle, to a more lateral position on your chest wall, which is not what people want. About 5 years ago, I switched to putting the implants underneath the breast tissue itself and above the muscle, so that's called a subglandular implant placement. I've been a lot happier with those results, and I think my patients have been too. Everything in plastic surgery is trade-offs. There's no free lunch. The big trade-off with putting the implant underneath the glandular tissue but above the muscle is that we know that's associated with a higher risk of capsular contracture and implant rupture. And that's a decision that, again, you as a patient really need to make. I think there's no question aesthetically the implants look better underneath the tissue, the breast tissue itself, but above the muscle. And I can't really quantify what extra risk you're assuming in terms of rupture and capsular contracture. But I think the goal with this procedure for most trans women is aesthetics. And I think most people, it's a very clear choice that they would much rather prefer a natural looking breast, even though they know they're assuming a slightly increased risk of capsular contracture and implant rupture. So again, it's a pretty easy conversation in my practice and my partner's practice. I use one type of implant. It's a round silicone implant. We typically have you come to the office, feel the implants, try them on to decide what your size is, which is the biggest choice as a patient. And once you've kind of touched the implant and felt them, you can feel how well made they are. The silicone gel inside the implant is very, very cohesive. It feels like a natural breast. If you cut an implant open, it's not like all the silicone just dribbles out and smears all over the place. It's a very cohesive, firm gel. Patients ask about, sexual activity, trauma to the implants. It's very rare with silicone implants that you could have rigorous enough sexual activity to where you would rupture an implant, although it has happened. Incision choice. So I use one type of incision. It's called an inframammary incision that sits on the lateral aspect of the breast and the chest wall. Depending upon the implant size, it can be anywhere from 4 to 6 centimeters. And kind of in contrast to the extra risk you're assuming by having the implant under the breast tissue, we know that the inframammary incision is the safest of all the incisions for implants. I've put implants through areolar incisions. I put implants through armpit incisions. Some people do them through the belly button, although I've never done that. The reason we think that the inframammary incision is the safest long-term is because we know the bacterial contamination at the time of placing the implant is associated with capsular contracture and rupture. You can imagine using a periareolar incision or an axillary incision. There are bacteria, there's higher bacterial load in the ducts of the area of the nipple, and obviously in the armpit. You're dragging the implant through that when you're placing it, and we think that's why there are higher rates of problems with the implant with those incisions. So I try to keep it simple. I try to keep it as aesthetic as I can, and I think for that reason, below the glandular tissue but above the muscle for pocket selection, using an inframammary incision for implant placement. What was the third thing? Oh, and then using round silicone implants kind of achieve those goals for good aesthetic breast augmentation. The implants always ride very high initially after the procedure. I joke with patients they're going to feel like they're in your throat. They're going to feel really, really high. There tends to be kind of a sharp sloped shelf on the bottom of the implant right after they're put in, because I typically need to lower your inframammary fold to have the implant in a good position and make sure your nipple is centered over the implants. All that changes pretty quickly in the first 3 to 6 months as the implant settles, as the sutures that are holding the incisions closed dissolve. and the implant assumes its kind of natural position on your chest wall. Even when I talk to patients about this, it's not uncommon. I have patients come in initially after the breast augmentation and they're looking in the mirror as like, wow, this looks really strange. You have to wait it out. The implants will settle. And we have before and after photos that show that initial implant versus 6 months. We're very happy with our results, and we think patients are too. So as a patient with breast augmentation, the biggest decision you have to make in our practice is how large-breasted you want to be. The average size implant I put in is about 450 cc's for trans women, which is about 100 cc's larger than for cis women. And again, the reasons for that is typically you need a bigger implant to fill up the available space on your chest wall. There are 2 ways to size yourself. The easiest way is to come to our office where we have all the implants, and bring a bra, pad your bra to a size you like. The other way to do it if you're coming from distance is kind of old school. It's called the rice bag test. It sounds very ghetto, but it works very well and it's very accurate. You take a Ziploc bag, you fill it with rice, you pad your bra, you keep adding rice until you get to a size you like, you measure the rice, and that correlates almost cc per cc with what size implant you need. And obviously, we always confirm the size of your implant before surgery. There is a little bit of a lead time with ordering implants. We need at least 3 days before your surgery date to make sure that we have the right size implant. There are a lot of other implants on the market. I commonly get questions about form stable or gummy bear implants. Those are implants that are shaped like a teardrop to try to mimic the natural shape of a woman's breast. The gel in those implants is very, very cohesive. I've used those implants in the past and I've really stopped using them. The reasons for that are, number one, if you hold a round silicone implant up in the shape it's going, or the position it's going to be on your chest wall, it naturally assumes that teardrop shape. To get the form stable gummy bear implants in, I need to make a much larger incision because I can't kind of compress the implant and kind of squeeze it into the pocket I've created. So those are 2 reasons. The third reason, and this is the reason I've really stopped using the form stable implants, aside from the fact that I think most patients don't need them, is that I've had implants rotate. So because there's polarity to the form stable implant, it has a certain shape. I've had the implants flip upside down, which looks bizarre. I've even had one implant flip completely over, and that buys you another surgery that, again, in my practice with breast augmentation, really should not happen. It should be a very, very predictable surgery, and because of that unpredictability that the form stable implants add, I don't like using them. They're also all textured, which again, as we've already talked about, puts you at a higher risk for, the elephant in the room, which is, could I develop a cancer after breast augmentation? And the answer to that question is yes. It's all about the risk, and we know number one thing that's associated with developing anaplastic large cell lymphoma is textured breast implants. Trying to think what else about breast augmentation. With breast augmentation, I have a conversation not infrequently that is, well, why can't I just have serial fat grafting to my chest? I've actually tried that for patients recovering from breast cancer who were absolutely against having any foreign material, i.e. an implant in their body. It just doesn't work very well. And if you think about the average breast implant being about 450 cc's for trans women, to get to that same volume of grafted fat, it's not impossible to do, but it's really, really close to impossible to do. And it involves multiple surgical procedures, multiple recoveries, multiple anesthetic sessions, and is typically not a good option for patients. What I do like to do in certain cases is to use fat grafting to help contour the implant to the chest wall, particularly for the upper pole and for the medial pole, again, to help accentuate the cleavage that's there. Some patients I think really benefit from that. Some patients don't really need it. Some patients want it. It's always a point of discussion. But that is a good use, in my opinion, of fat grafting for breast augmentation. Again, not to actually create the breast mound, but to help feather the breast mound and help accentuate cleavage areas on the chest wall. Complications from fat grafting in the chest are typically a little bit higher than for the face. The reason for that is I'm injecting more fat. The fat can atrophy, like we've already talked about. Roughly 50 to 60% of the fat that I graft takes. The fat can calcify, the fat can form oil cysts, and in some cases the fat, what was I gonna say? Can atrophy, can form oil cysts, and in some cases the fat can actually become infected. Typically that doesn't need to be treated surgically, it just needs to be treated with antibiotics. Grafted fat is always lumpy. It needs to be massaged to help it contour out, and I go through that with all my patients, protocol for massage after fat grafting to help the results. So we talked a little bit about picking implant size. There are different profiles to implants, and this is much easier explained visually when looking at different types of, again, round silicone implants. You can have a certain volume for an implant that can be achieved in a smaller circumference of the implant. With that, you get some increase in projection. So with a low profile implant, it's flat, almost like a pancake. Say it's a 500cc implant and has a diameter of 18 centimeters. You can have that same 500cc volume in a moderate profile implant where the diameter may be 16 centimeters, but the projection, how far the implant protrudes off the chest wall, may go from 3 centimeters to 4 centimeters, which is why we always see patients preoperatively, irrespective of how large breasted you want to be, to make sure that the implant profile and size that we are choosing fits your chest wall optimally.
Thank you for watching this educational video on breast augmentation. Should you have any further questions, please contact our office or visit us online at cranects.com. Thank you.